Hi, in this lecture, we will be talking about a patient that has schizophrenia. So this is the very first lecture of the series for learning purposes. And also there might be some typos since this is going to be the very first lecture. We will try our very best to um, do as much real life scenario as possible. Again, this is for learning purposes only. And the names of the patients are not real, and the scenario is somewhat made up. However, it's as much um, real as possibly it can be. So let's begin. And like I said, the purpose of this video is for learning purposes. It could be for students. It can also be for learning purposes for any medical related professionals, nurses, or anybody that would like to learn more about psychiatry and psychiatric treatment in general. So in this particular instance, we will actually be talking about a patient that's presenting to inpatient psychiatric hospital, and the patient comes in with auditory and visual hallucinations. The patient is 27-year-old female. Let's name her Ashley Johnson. That's a made-up name, 27-year-old female, presenting to the inpatient psychiatric mental facility. Patient has been presented from nearby emergency room that's referred her because she presented to the ER with voices that are telling her to harm herself and possibly harm others. She is also hearing voices and seeing things that are demonic in nature. All of this started about a week ago when the patient stopped taking her medication because she ran out of her refills and she did not have an appointment or neither the resources to make another appointment with her psychiatrist. So, uh, as a psychiatric provider or as a nurse practitioner or even as a psychiatrist, what would you do? So the very first thing to do in this one is we will do the initial evaluation for this particular patient. And the initial evaluation, uh, we will talk to the patient. Uh, while talking to the patient, we will pay attention in particular to the patient's appearance, uh, to the patient's language, patient's body language, and how and what is she saying. So, and that includes the part of our mental status exam. Mental status exam, as we talked previously, is very important in conducting a new patient evaluation for a psychiatric intake patient. It tells us a lot about a patient. So, for example, their appearance is very important. Are they neat, clean, well groomed, well dressed, or are they uh, dressed inappropriately? Their dress is unhygienic. Their hair is not clean. Their appearance is disheveled. And then pay attention to their speech pattern. How is their speech pattern? Is the speech pattern congruent with what they're saying? Is it Are they speaking in a normal tone? Are they speaking at normal um, pitch level? Their voice and their thought process, is their thought process linear? Is their thought process non-linear? Is it tangential? Are they changing subjects very rapidly? Are they keeping the subjects linear, or they switching subjects? And also their thought content. Is the thought content related to the normal everyday life? Are they talking about dying? Are they talking about killing someone? These things are very important. And are they logical? And do they know where they are? And also, do they um, have a sense, do they understand they actually have a mental illness or not? So these things are really very important to key in on whenever you are doing initial mental evaluation. So let's talk about this patient, Ashley, paying close attention to what she's saying. So the patient presents and she's saying that she is hearing things that are telling her to harm herself, and she is seeing things that are telling her to harm herself. It has been going about over a week now. Um, and all of this was triggered when she stopped taking her medication, which was prescribed to her by her psychiatrist. She was taking risperidone, 1 milligram every night. So then what we have to, take into account is, okay, so risperidone is an antipsychotic. It's a second generation antipsychotic. So the patient was taking this medication for her hallucinations and delusions. So immediately we could confer that the patient is hearing and seeing things. She has possibly a psychotic disorder. This can also present with some other mental illnesses concurrently. I mean, there can be depression, there can be anxiety, but just listening to what the patient is saying, we can infer that definitely patient has um, schizophrenia. So schizophrenia is, listening and seeing things and actually believing them. So we could, diagnose the patient. There are different types of schizophrenias. We have to go by the DSM-5 for the schizophrenia uh, diagnostic criteria, and that's also an assignment. I would like you guys to properly diagnose this patient. If she is hearing things, seeing things, um, you have to pull up the DSM-5, the purple book, and look at the ICD-10 codes to properly diagnose her. But this one is a classic example of schizophrenia. And then we also have to take into account other things related to the patient. So what does her social history look like? Does she live alone? Does she live with someone else? What does she do? Does she actually has a job? Um, does she does she have children? Is she married? Is she single? And then also we have to take into account her medical history. Is she currently on any kind of medications? When was the last psychiatrist visit? Was she ever inpatient hospitalized? And for what was she hospitalized? We have to take into account her suicidal history. Is she currently suicidal? Uh, was there any suicidal attempts in the past? Um, does she, if she is suicidal, most important thing to ask is, does she have an actual plan to harm herself? And what does that plan look like? Okay, so that's very important for us. The more concrete the plan is, the longer that she will have to be hospitalized. And if she is found outpatient and if she has a plan to harm herself or harm someone else, we have to call the 911 and have this patient be committed inpatient, hospitalized, inpatient psychiatric hospitalization, um, in order to um, keep her safe and others safe. So for this particular patient, we also have to make a treatment plan. For her, we will possibly reinitiate the risperidone 1 milligram. If she is really psychotic and she's saying the voices are immediately telling her to harm herself and anyone else, we can do 1 milligram 2 times a day. Risperidone can also, any kind of antipsychotic medications can have um, adverse effects. So the possibility of having adverse effects are possible. So we can start her on a cogentin along with that. Cogentin is, or benztropine is anticholinergic medication that stops the side effects of antipsychotics such as stiff muscles, locking of jaws, um, and these side effects can be mitigated by anticholinergic medications. And then we will continue to monitor this patient, and we will reevaluate her the next day or in a couple of days. Thank you.